Director of Indiana University Health Bloomington's Hospice and the Medical Director of the Palliative Care Program. We are doubly delighted tonight to also have Dr. Andy Coates, a past president of the Physicians for National Health Program, a former union leader, and currently assistant professor of medicine and psychiatry at Albany Medical College. And he is going to talk about what the community and the medical profession can do to support doctors who are taking a stand against privatization of healthcare and what might be the role of physician unions. So I'd like to start by asking Dr. Robert Stone to join us. And we have some questions that we would love for him also to discuss. And as has been mentioned, Dr. Stone, you've been around your hospital system for quite a long time, playing a role in palliative care, emergency department, etc. So my question to you is, were you informed that your practice was joining an ACO REACH? And did you as a physician have any say in this? And I'm asking you that because many physicians who are employed by hospitals don't even know that they're in an ACO REACH, just like the patients. When the physician signs up or the hospital signs up, the patients very well may not know that they're in an ACO REACH. And with all the roles that you have played in your hospital system, it would seem to us that it would be easier for someone like you to fight back. But it doesn't look like that might be the case. So how do you think other doctors facing a similar situation such as yours would be able to respond? Can they push back and claim that they do not want to enter into this kind of a for-profit healthcare program? Take it away.
So I'm glad to be here tonight, and I'm in the midst of a pretty interesting adventure, and so I'm looking forward to being able to talk to you about it. I have been an activist with PNHP for a long time, and been very active in issues around the original DCEs. And so we need a little more muting out there, if we could get that. Thanks. So I was on the lookout to see what my hospital was going to do with the ACO REACH after the DCE thing changed its name to ACO REACH. And I should just say that, so it's a big hospital system centered in Indianapolis, and it's the hospital system associated with Indiana University School of Medicine. And there are smaller hospitals around the state. So I'm in Bloomington, Indiana, which is where the main campus of Indiana University is, but the medical school is primarily up in Indianapolis, about an hour north of me. So I've been in Bloomington since 1983. I was on the lookout, wondering what our hospital system, so it's not just my hospital, but it's a whole system, including a couple of very large hospitals, what it was going to do. And then on Wednesday, July 6th, I got an email that on my work email account that said, "Hello, this email is on behalf of the Indiana University Health ACO Incorporated, and we wish and this is written notification that the ACO wishes to add you as a provider." But it goes on to say, "This email is for your information only. No action is needed from you at this time. This does not impact your provider's employment, role, or duties as a provider, and doesn't change the way providers currently care for patients." So it said, this email is for your information only and no action is needed. So of course, I immediately wrote back to them and said, I don't want to be a part of an ACO REACH. So this is in early July. And I received a reply a few days later from the ACO REACH, which all that bureaucracy is up in Indianapolis. And I got a notification back that said, it's fine, we'll honor your request. You won't be part of the ACO REACH. But that very same day, I got a call from the administrator of my boss of our physician group. And he wanted to meet with me. And so we met soon thereafter. And he told me that the part of my job requirement, and he's a very nice young guy. He's a very earnest fella. I've known him for a number of years before he rose to this position as essentially my boss. And so he was very deferential to me. He was a little nervous about the whole thing, but he told me that my employment agreement really requires that I participate in everything that the whole system is participating in. And this is a standard bit of any physician's employment agreement. And so here's where I'm going to pause for a second and say that, so once he told me that my job was potentially at risk, then I knew that I had to take certain things to be very careful about, because most physician employment agreements do contain some confidentiality clauses and so I don't want to reveal anything that would then give, if things do get nasty, and we don't know how things are going to be, and you'll understand that pretty soon as I tell the story. But if things did get nasty, I certainly don't want to provide the hospital system other ways that they could legally attack me and make my life miserable. So, and I also don't want to do anything at this point that would be judged possibly as causing damage to the reputation of my hospital system. So those are kind of the areas where you may ask me questions that I'll have to be careful of, but I made it clear to my young boss right from the very start that I did not want to participate in the ACO REACH. I wanted to keep seeing and taking care of my patients, and my goal was that I can help convince Indiana University Health to drop its whole ACO REACH program. So I just told him that on day one. So he told me that this issue of my request was going to need to go up to the board, and we were going to have to get some more opinions on it. And so, and he said it'd probably be the end of summer before that goes through the different steps. And we're going to, and our job as a hospital system is we're going to need to set up a precedent and decide what the rules are. And so then I didn't hear back until in September. And in September, he and I got together again, and he said, yes, the board has decided that you have to be a part of this program. And I said again, well, I've already gotten written notification that I don't have to be a part of it. I want to keep taking care of my patients, and I would really like to see Indiana University Health change their attitude on this and remove the whole ACO. So we talked a little bit more, and I've gotten nothing in writing saying that that I'm going to be fired, but it's been made clear verbally that if I don't participate, that it might come to that. And so I'm standing my ground that I don't want to retire. I don't want to stop taking care of my patients. I don't want to be part of the ACO. And so my young boss said that he would get back to me again by this coming Friday. So it'll be interesting to see what I learn on Friday. But the other thing that happened then a little bit just last week is that I didn't get another email, but patients of mine sent me emails that they were getting And these emails, so these were emails sent to patients who were people on traditional Medicare. And they, and this email says, hello, your provider is voluntarily taking place in a new initiative by joining Indiana University Health Accountable Care Organization. Together, we think it will help us provide better quality care for our patients. Your benefits will not change. This is in bold. And you can visit any doctor, other healthcare professional, or hospital. And then there was a link where you could look up your primary care physician and see what it said about them. And so, since I'm not a primary care physician, I'm a consultant as a palliative care doctor, I didn't show up on this website list, but I looked at for my primary care doctor, and sure enough, she was there. And so when I went down on this website, down the drop-down menu, and found my primary care doctor's name, it said Dr. So-and-so. Again, the first thing it says is, your doctor is voluntarily taking part in a new initiative by joining Indiana University Health ACO. And so, and I checked several other names on the list of docs who I know and who are primary care, and they all were shown with this statement, your doctor is voluntarily taking part. And I asked all of them, and they all confirmed, no, they never heard about it. They might have gotten that email I got back in July that says, you don't need to do anything, you don't need to respond, but none of them actually voluntarily agreed to participate. So I brought that to the attention of my young boss, and it was actually the first time that he got a little bit annoyed with me, because it obviously made him uncomfortable that this stuff is going out now. And I didn't feel any concern about actually reading to you from those emails, because those were sent out publicly. So they have nothing, and they don't say anything about my employment agreement or anything that's confidential. So they are in a difficult spot here. And you know, I'm a well-known physician, probably without being, hoping not to sound too conceited, but I'm kind of a beloved character in this town, even though I am known as a gadfly, as a troublemaker, as a single payer advocate, and all that sort of stuff. So they're in a very interesting position. And they're touting this thing as voluntarily this, voluntary that. My guess is that the people who run the ACO, who are some bureaucrats in a big office building in Indianapolis, don't really even understand what they're doing and what's going on. And my bosses here in Bloomington were really they were actually, my young boss was initially surprised when I told him I'd already gotten a letter saying I didn't have to participate. So that's kind of my story, and I'm sticking with it. And I'm gonna want to let this play out for a while. And I am so curious, though, and one of the things I'm hoping to accomplish today is by spreading the word out a little wider, because so far through PNHP channels, I'm on the board of advisors of PNHP, I guess I should add that too, and I used to be on the board of directors of PNHP. We've not been able to identify another doctor in the country who has made this declaration, but it seems like there must be some other people doing this. But I think what's happening is that all these systems are moving forward. They're trying not to draw too much attention to it. And so I don't know what's going to happen. So I'll leave it open to questions now. But I will tell you that if my choice is to not be able to take care of my patients, it's possible that I'm going to choose that. Because I want to keep taking care of my patients. I'm not ready to retire. And I only see patients 2 days a week, but I might choose that. But I sure am not going to voluntarily choose to be a part of this ACO REACH, which is a bad actor. We all know that. So from there, I'll turn it back to you all.
So thank you so much, Dr. Stone. As you just described it, is that what you meant when you said that you felt that you had moral leverage over the decision-making process of an ACO REACH?
Actually, I think what I said in a conversation, an email with Anna, is that my employer has no financial leverage over me, because I could have retired years ago. I'm definitely not working for the money, and but I feel like I've got the really, the moral leverage over IU Health, and so I'm willing to play with that. Really, the leverage that they do have over me, though, is that even though they don't have financial leverage, I do want to be able to keep taking care of my patients. That's pretty important to me. I've thought about that a lot. And certainly when I come home from a really hard day, sometimes I feel like, okay, this is hard work that I do, even though I've limited it to 2 days a week. So that's kind of, that's where that comes from.
Are there other doctors in your institution that you're aware of that have similar feelings as you do?
Nobody has told me yet that they're willing to drop out of the ACO REACH. I've not really beat the bushes. I've contacted, half a dozen people. I actually gave a grand rounds at the hospital back in July, but our local hospital grand rounds have become not a very big forum. I mean, it's actually the Wednesday noon conference, kind of in the format of grand rounds. And I gave my every July around Medicare's birthday, I give my Medicare's birthday single payer 101 speech and present it to the community. And then I ended it with some mention of the ACO REACH, the DCE stuff. And so I told it, quite publicly, but only to about 30 people, 5 in person and 25 on Zoom. So I haven't. So I'm one of the balancing acts I'm trying to do is, my goal is to get them to stop the ACO, to withdraw from it, and I think my best leverage to start with is by doing that in my usual style, which is to be direct but kind. And that's just kind of who I am. And so I haven't really tried to kind of stick it in their face yet, but I have been agitating, and I haven't made a secret of it. I'm trying to find a balance here, and of course, all this calculation is going to change a little bit on Friday, if and when they get back to me then. And then it will really become, at a bit more of the tension will rise a little bit as we get closer to January 1. But the program doesn't even start until January 1. So there's nothing that about me complaining about the program or threatening not to join it that is anything that could get me into trouble legally. It's just if I actually refuse to participate after the thing actually starts, I think.
Well, January 2023 is pretty soon.
It's coming right up.
Yeah, definitely. Were the terms of the ACO REACH explained to you, and were you given any possible financial incentives by the program? I hope that I'm not being too nosy.
No, I think that's okay, because I don't, I think that's okay. Yeah, no, the ACO REACH remains this really vague thing. I got this one email that was mostly all about how this isn't going to change anything, and don't worry, and you don't even need to reply. And then patients are getting these things now, which seem like they are written to try to give some kind of actual notice to people without, but in other ways, trying in every possible way to not draw any attention to it or get anybody worried. So yeah, so I've certainly not been coached in any way about or given any sense of there would be advantages for me or anything like that.
So they didn't mention that the reimbursement for fee-for-service billing from Medicare would actually be lowered, the reimbursement rate, in exchange for increased shared savings from the ACO REACH?
Yeah, they didn't say anything about that because that won't affect my salary.
Mm-hmm.
You know, I'm paid on salary,
Right.
so it would affect the system's overall cash flow for sure, but it won't affect my salary.
Okay, because I know that for many of the ACO REACH programs, they're saying that the doctors will benefit by having less paperwork and have more time to spend with their patients. But in exchange for that, there may be some changes, in what is going to be collected and what will actually be shared with the physicians.
Oh, that's interesting. So that would be, I'm assuming then people who are in smaller groups or in private practice, or yeah, but I'm a salaried physician.
Right. Well, as you know, most physicians these days are, because they can't
Yeah,
really
yeah.
afford to be not salaried out in the real world. And also, there's supposed to be more physician representation on the boards of the ACO REACHs. And that's one of the supposed advantages of ACO REACH compared to the DCEs. So just wondering, I guess you weren't invited to be part of that board if you've already said you didn't want to become part of the REACH. But
Right.
if you were, do you think that being on the board would in any way be really an advantage, that you would be able to change certain of the processes of the ACO REACH to be more morally responsible as you see it?
That'd be an interesting thing if they offered me a spot on the board. There was a time when I was trying to get on the board of Anthem Blue Cross, and but I wasn't able to quite swing that because I thought that would be pretty interesting. They're headquartered in Indianapolis, but I don't know, there's also this part of me that says I really don't want to go on any more boards. I've spent a lot of time on boards in my life, but that would be interesting. I'd certainly love to speak to the board. As far as I can tell, I have seen the board of the ACO. No, I don't think I've seen the separate board of the ACO REACH. But I think the ACO REACH, the IU Health one is probably gonna very easily show that it's 75% physician influenced or whatever. I think, I mean, in many ways, I'm not particularly worried about the IU Health ACO REACH becoming a really bad actor. Indiana University Health has had a Medicare Advantage program for years, and so far it's not very big, and they haven't had any false claims, whistleblower charges against them yet. They're not necessarily going to be bad actors, but that doesn't make them any better from my perspective, looking at the overall policy, because the same bad actors who have given Medicare Advantage, all the well-deserved bad publicity, are trying to move into the ACO REACH market too, as we all know.
Have you, Rob, Dr. Stone, contacted any organizations asking for any kind of support in your moral judgment and decision making? And I guess as a fellow PNHP member, an activist, do you think that a single payer organization would be able to help you in this morally justified fight? And how could other physician groups possibly be of help?
So right now, I've had a lot of contact with a lot of people in PNHP, and it's still not clear exactly what kind of help I need. There is this potential that I would need legal support, and that could be, extremely expensive. But we're not there, and I haven't pulled the trigger on anything like that. I've talked to a number of people also locally who are a couple. One person in particular used to be the administrator of the hospital, and she's a good friend and a closet leftist, but a hospital administrator. So what I'd really like to do is connect with some other docs who are looking at this, and but I haven't made that connection yet.
Well, as you may know, more physicians are trying to join unions and striking, and a union can bring some protection. Labor laws allow the employee to bargain for wages and hours, conditions of employment, and a union is at least the first line of defense that can bring some protection. Do you know if you're eligible to possibly organize? And do you think it would benefit doctors and other healthcare workers to be unionized as a way to increase our protections? And especially in a situation where certain workers would not want to join an ACO REACH for moral reasons.
Mm-hmm. Well, I'd certainly, I'm certainly a pro-union guy, and I'd love to hear from Andy Coates on this. Unfortunately, Indiana is not a very labor-friendly state, and but it would be an interesting thing if we unionized, and whether something like ACO REACH participation would be a part of something that could be that a union could deal with. I don't know.
Well, that's, I think, one of the reasons that we have Dr. Andy Coates with us tonight as well. So I would love to invite Dr. Coates now to speak to us specifically about this question of unionizing to protect physicians' moral rights and judgment, and try to avoid a conflict of interest that would develop, we believe, under an ACO REACH program. So Dr. Coates, could we invite you to speak with us about this situation?
Can you hear me? Yes?
I can.
Okay, good. I didn't realize that was my assignment. I do have a life experience of leading a union. It was, in fact, a nurses' union in the hospital that I was in. Yes, all the doctors were in the union as well, but it was the Public Employees Federation in New York State. So PEF, which is an affiliate of the American Federation of Teachers and the SEIU both, and I used to joke, you can't do better than that, may organize more doctors than any other union, because there are 54,000 state workers, or 50,000, I don't even know the number anymore. Once upon a time, 50,000. I don't know how many doctors. So I have this experience of leading a local union in a statewide public employees federation, and public service for physicians is completely different from what Dr. Stone is talking about. Of course, my feelings about work would be that obviously people should join unions. I would like to see an Amazon warehouse workers union. I would like to see a baristas union. I would like, one big union. I think that's an old demand. I like this idea. Organizing doctors is a very, very complicated question. There's a lot of false consciousness. There are, in fact, doctors who are aggressive business people who own their own labs and radiology facilities and make more money than God. So it's a very, very tricky question. I think this is a marvelous meeting. My life right now is revolved around trying to build a teaching service for students with the philosophy that we should be educating doctors for the 21st century, not the 20th century. All of our methods are geared to the 20th century. The small shopkeeper fits in the union thing here. And what does it mean to have a profession in the 21st century? I think Dr. Stone's detailed explanation of his personal struggle is so revealing. I think it is resonates, I'm sure, with every corporate employed physician in the country on some question. Maybe this question is his, kind of life or death question right now. But there are other questions that other physicians face, surgeons with OR time and the struggle against the anesthesiologist that just went private, and how can they get their patients in a timely way. I know that Larry Woodson was the kid in the back of the room, just wanting to talk. And the whole question of how doctors get paid is something that's opaque. It's opaque not to the public, it's opaque not to the patients, it's opaque to the doctors themselves. Dr. Stone knows what his compensation is because that's his deal with them. I know what my compensation is. I'm glad to hear you're salaried, Rob, because I get paid by the goddamn visit. If I don't make a visit, it won't be in my paycheck. If I take a vacation, I don't make the visits. That's the terms of my employment. It's dressed up to be a salary plus quote unquote bonuses. It's a salary plus lag pay. It's a scheme. It's a corporate scheme, and it is, in my opinion, the least defensible. So when you think about like what it means to be a doctor in the 21st century, this particular question gets swept up. I think the big point is that if you try to profitize the relationship between a physician and a patient, a nurse and a patient, a phlebotomist and a patient, any caregiver for that matter, an aide, the person that cleans, you try to profitize that relationship, you have incentivized cheating the relationship of resources. That's an objective fact. This is how it works. You're going to profitize the nursing home room. You're going to try to take a profit out of that room. That means there's something that's not going to go to the patient that otherwise could have. Public provision of healthcare is the only ethical and defensible provision of healthcare. It's the only accountable provision of healthcare. What is happening with this ACO REACH scheme is a complicated and ideological idea that if someone makes a profit, it will somehow be more efficient, it will somehow be better. The ideology is that if there's a profit made, it's a better product. It's an ideology. It is absolutely contrary to fact. The fact is, if a profit is made, those are resources that should have gone to the patient. That's how healthcare is. I could say a lot more. I would like to. It seems like there's a lively discussion about Dr. Stone's predicament. And I think that it's incredibly enlightening. And I think that the truth will set us free, and focusing on the minutia of some of this is incredibly liberating. So I'm going to stop there, but I'm available to continue. I hate being on camera, but I'll try to stay on camera.
So can I just interject, Andy, you're welcome to, we have plenty of time. So if you wanted to make more comments, or if you wanted to ask Rob questions, or if Rob and Andy wanted to have a conversation, please go for it.
Well, why don't I take your Rob? So my students, it blows their mind that they're going to have a corporate employer. And how do you go into how do you tell your senior resident, right now, my senior resident, he's a med-peds resident. He has a dream of being a med-peds hospitalist. I know that in community hospitals across the country, these things exist. I know some of our local communities where med-peds hospitalists have been very successful. How do I counsel him about his future employment? What it means to be a physician with all of the privileges and all of the aspirations to serve the community that we know he has. This happens to be an individual with all of the best social determinants of health questions in mind, all of the injustices in our society he would like to remedy as a doctor. How do you counsel someone like that who's looking for a job? This is a practical everyday thing.
You're asking me to try to comment on that, Andy? Yes. And I do some teaching, of course. I am so struck by how these terms like social determinants of health are so prominent in the curriculum and really diffuse deeply into the medical school curriculum, but not really addressing the question that you've said. How do you actually do that within a corporate structure. And I work for a large nonprofit, and it is it still has, at least I want to believe, some elements of a soul, but it's I used to be in an ER group that was an independent contractor with the hospital, and then we were subsumed into the larger hospital in around 2010 or so. And I've watched all this through my career. You've watched it all through your career, and there's a part of us in PNHP that we say, well, more and more physicians becoming employed is maybe a good thing, because it's going to because we have seen, for instance, the American Medical Association and particularly my previous specialty society, the American College of Emergency Physicians, so dominated by the entrepreneurial physicians, and those people who are really entrepreneurial really rose to leadership spots in these organizations. And so, so I know what the entrepreneurs are like, but now I'm part of a nonprofit that is affiliated actually fairly loosely with the university. And it appears to me like it has become such a big thing. The overarching corporate structure seems so vast and impenetrable that I do wonder, how does one doctor take a stand without figuring out some way to actually organize in something like a union? And but I don't know how feasible that is going to be. What do you think, Andy? And then we'll take some other questions.
Well, I think that there's a theme, which is that the organized medicine, you mentioned the entrepreneurial current in our profession, taking leadership roles, and who speaks for us. There's a famous time, I love this history of the AMA. I know that you know it well, but the only time the American healthcare system was systematically surveyed to try to come up with a way to provide care for all was the Committee for Cost of Medical Care in 1928, 29 to 1932. 33 volumes they published. The chairman of the board was Ray Lyman Wilbur. I love that because he was past president of the AMA, past president of Stanford University, and he was a Herbert Hoover appointment to the cabinet of the Republican administration. And they were red baited by the AMA. They were red baited by the AMA because they said that there should be some kind of health care for everybody in 1933. They timed it for Roosevelt's inauguration, and the AMA was ready with red baiting to take the side of profiteering over patients. So there's this deep current in our last century on our profession of taking the side of profiteering.
Well, that mutes me.
Okay, you want to see it?
So that's a very big thrust. And I think that when some of these schemes come along, that if we can upcode sufficiently and we'll get a bump in our salary, the idea is, well, we can game the system. And I often joke that what medical school really teaches is how to subvert any system. I don't know if the herding cats metaphor doesn't really get to the depth of how subversive doctors are when it comes to subverting a system. So I think we have this individual arrogance deep in the profession that we can somehow survive individually because we're going to be in charge. Because we're the ones that give the orders, no one else gives us orders. And that's a very profound observation. So I'm saying that the cultural things that you're pointing out are completely part of trying to educate our patients and our communities about these schemes that come along. In this case, I think, Cheryl, you're spot on. This is a scheme that pushes toward capitation to try to push the risk onto the doctors unwittingly here. Now, someone like Dr. Stone or myself, the hospital would take the profit. If we were able to upcode and reduce length of stay, the hospital would be glad to take the profit and not share it with us. Their bean counters would prove it, and they would get that better. And that's kind of how that works behind the scenes. I think the question of how to educate, how to use the profession in the old-fashioned way to educate the community is very sincere and very much a responsibility. And to recruit, you know, Dr. Malino, how do we recruit our colleagues to really get out there in the public? Something that's been on my mind lately, I know I'm rambling and I apologize, but I hope it's useful. Something that's on my mind lately is this ethic that we're not going to really talk about our patients ever outside of the room. We're going to keep something there in the exam room. And when a terrible, terrible injustice happens, like a patient getting cheated out of their care in the richest country on the planet, which if I look at every case, I can find something in every single case that the patient could have had a different medication, a different test, an earlier admission, better follow-up, better communication. There's something they got cheated out of because of the way the system is organized. I think that if we were to really step up and think about how to educate as the profession is meant to be related to our society, we'd be in a very different place. So I'm in awe of your stand on this, because I think it does exactly that. Explain how this scheme would cheat the patients of what we should have. I think the problem of winning more people to that cause is very, very important, especially right now.
So, Dr. Coates, thank you so much. We really do appreciate the reason we're all here tonight with you and with the group is specifically to educate everybody who is here and to go back into their community and educate everyone even further. I'd like to maybe hand over to Sandy Fox, who's been looking at the chat and looking at the questions so that we can pick both of your brains even more and get more information that we can continue to give out to the community. Sandy?
Thank you, Cheryl. There were 22 questions, and I'm going to filter through some of them because for time, but also because I think some of them were already answered in the course of the program by Rob. One of the questions early on from Elsa Schaefer, Rob, is who in your system made the agreement with the ACO REACH?
So, yeah, Indiana University Health is this large system of hospitals and physician group, and it used to be several physician groups, and it's trying to turn it all into one big physician group. And there are, I think, what I say, 6 or 7 hospitals around the state. So it's a big entity, and it's affiliated with the medical school, affiliated with the university. And so it got into the idea of, it was an internal decision was made that IU Health should do its own Medicare Advantage program and try to, add to our bottom line. So it's not called a profit, it's called margin because we're a nonprofit, but it's the same thing. So it was the idea of just, we don't want to leave any money on the table. Our competitors are doing this, we're going to do this too. And so it's the same thing with the ACO REACH. I mean, there have been these other ACO entities that started, you all probably remember, with the Affordable Care Act. And so that was an Obama thing, was to try to do these things called accountable care organizations, ACOs. And I've been a part of the IU Health ACOs up till now, because it was completely in the background as far as I could tell. There was no risk sharing in these old ACOs. They were just these schemes that were that had these ideas that they would make things more efficient and somehow save money and improve quality. But the old ACOs were, I mean, that's a whole long, very nerdy discussion about the previous ACOs. So this new ACO REACH thing is, as we've pointed out, an orders of magnitude much more problematic entity. So I've never objected to being a part of the old ACOs because they were ineffectual and they were not worth wasting my time on, is how I felt it. This new ACO REACH is this newer entity that has all this bad potential and has no good side that I can tell. But it was just something that the people who kind of look at the bigger administrative and financial sides of our health system said, oh yeah, we should do that. Everybody else is doing that. You talk to any consultant, they're going to say, oh yeah, you should do that.
Hmm. Yeah, this next question comes from Judy Albert. What would be different? And I think you've alluded to this because there's a lot of unknowns here. But in your opinion, what would be different about participating in the ACO REACH versus not participating? How would you carve that piece out of your practice?
So, so I'm not sure. It's hard to tell. Because it doesn't exist yet. And so from my employer's perspective, they just want everybody to participate and to give them perhaps more due than they really deserve. But really, my employers they're not bad people. They're playing in a bad sandbox, but certainly one reasonable argument that they could make is that what if some anesthesiologist said they didn't want to take Medicaid? Is my choice to not do this, would that in any way then be a precedent and a slippery slope that some doctors could refuse to take Medicaid? Because certainly lots of doctors in private practice don't take Medicaid patients because they don't reimburse as well. But our entire system takes care of Medicaid, takes care of no-pay patients. I mean, we are still a charitably driven nonprofit organization. So in the sense, if I make this choice to not participate in this little tiny part of the whole IU Health, it does need to be done in a way. I don't want it to become a way that could become a precedent that doctors could refuse to be in Medicaid, for instance.
Right.
And also with respect to the upcoding game. So if you are a hospital, you're getting paid on the DRG system, which means that the upcoding game applies to every inpatient in the hospital.
Right.
And most hospitals now have a clinical documentation team, meaning a team of nurses who are very sophisticated, looking at the chart saying, well, wait a minute, you wrote K+, we need you to write hyperkalemia, because hyperkalemia codes to an ICD-10 code that codes to a comorbidity.
Right.
And we need to never miss a major comorbidity, because if we miss a major comorbidity, we're leaving tens of thousands of dollars on the table for the hospitalization. Every doctor in every hospital is somehow in part of this game that's already happening as part of the culture. And so the hospital may be doing very well on getting the doctors to document in the magic words that get the money. And if they already know that, then joining the ACO REACH is a no-brainer, because they will have the magic words in the chart already and get the money, whether or not they compensate the doctors, whether they're just simply gaming this system, because of the DRG system set this all in motion, which, by the way, is a Reagan era way to save money by privatizing the system. And then it has introduced all of these perverse incentives. And in my opinion, it's even spawned specialties. The idea of the DRG capturing. So this is part of the modern day medical culture, and to wake doctors up and say it doesn't have to be this way then becomes a very, very, very heavy lift, because we're talking about 40 years of this becoming the culture.
Wow, that's very informative, very helpful. Scary to think how far back that goes. This question is from George Baumfalk. Rather than reacting to done deals, shouldn't physicians proactively approach their system leaders in hopes of educating and forestalling their signing on with ACO REACH?
I think that makes sense. That's, as I said, in my case, I was kind of looking for this. I responded to it. I'm still, in terms of trying to figure out my strategy, trying to what my next steps might be, but I'm going to continue trying to figure out. I do besides being not a doctor. As a doctor, I do two things. I take care of my patients, and I organize toward an ultimate goal of a universal single payer plan. That's my life, Luckily, I've got other things in my life besides just these doctor tasks, like my grandkids and my wife and my garden and that kind of stuff. But yeah, my professional time is right up there with taking care of my patients, is figuring out how to organize.
Mm-hmm, mm-hmm. This is from Mary McDevitt. Do you intend to get a lawyer?
Well, I intend to talk more. I've talked informally to some lawyers, and I don't know if I'm going to hire a lawyer. That is an open question.
Mm-hmm, mm-hmm. Okay. Carol Yost asked the question, how can we fight this? Which I think you've alluded to in other ways, but is there anything else you would like to add to that?
Well, I think, I would, if you all can all kind of check around and see if you can find anybody else who's doing this, I would love to be in contact with them. That would be really, really useful to me.
Mm-hmm.
And otherwise, we're all just kind of doing the work we're doing. And, this is great having, what do we got? 89 people on this call right now. Yeah, every way we can figure to organize, every way we can figure to fight all this. It gets a little overwhelming because there are so many battles to fight. But part of what keeps me going is that I get to meet wonderful people and build relationships around the country and be on the right side of history. So those are all things that keep me working.
Yes. The next question from Lenore Ahrens, I think, again, you've talked about how will being in the ACO REACH change your practice, and it seems to me you've said you're really not sure at this point, except you know what the motive is, and it's contrary to what your motive is by being a physician. Is there anything beyond what you've already said you'd want to add to how you think it would change your practice?
Well, I've thought about that. Really, as I mentioned, I've been a part of these earlier ACOs, which were pretty different animals. And participating in the ACO REACH, it would probably be a very small number of patients, and it would be very easy for me to never know even who those patients are. I don't foresee that that there's going to be much going on, at least in the first year or so of this, that I'm going to perhaps even be aware of. It's all, as Andy said, there are already all these systems to gather diagnoses and upcode and that sort of stuff. And so that's all going to keep going on. So I don't actually expect that there's going to be anything that I'm going to face difficult moral decisions. If I did decide to go along with being in the ACO REACH, not my first choice, but if I did decide to do that because I decided overall that I really want to, I don't want to, if I'm forced to make that choice anyway, I might decide just to be in the ACO REACH. I guess I'll leave it that way. And I actually don't expect it to be burdensome at all. I don't expect it would ever come up that I would have a particular patient where I would say, oh my God, because I'm in the ACO REACH, this patient got screwed. I mean, I think this whole thing is being so cleverly worked out. They're moving more and more of the money siphoning effects of healthcare farther out of physicians' viewpoints or view. So no, I don't think it would be hard for me to be a part of the ACO REACH. I think it would be invisible to me. I just don't want to do it because I think it's wrong.
Yes, and the follow-up question to that is from Ed Gristar is, what is proposed that will change your working conditions on the job? And basically, I suppose the answer would be the same. It might be invisible to you. But I
really
wonder if it would be
wouldn't change.
different for a younger physician. I mean, you've shared, Rob, that you have clout. You've been in the system a long time. So that gives you some leverage. I wonder if it would be different from compared to a younger physician entering in terms of working conditions and pressure.
Well, certainly a private equity firm that hires the doctor is going to incentivize all of these things directly in their thing. You know, Harriet Seiler talks about the innovation. I think everybody should know Liz Fowler's name and Google her illustrious career, going from WellPoint to writing the Affordable Care Act to being in Obama's cabinet or helping Obama's cabinet to then being for Johnson & Johnson, then going back into Biden. I mean, health policy in the United States is bipartisan, and Liz Fowler is an emblem of the revolving door between the industry. I just think that we should know that. I think that there's an important thing for this meeting to know, which is in 2013 in Madrid, Spain, there was this unbelievable rebellion. There was a move to privatize and profitize the public health clinics of Madrid. And the doctors and nurses and patients together shut down traffic in Madrid and stopped the privatization and the profitization of the Madrid healthcare system. And the way that came about was there's a small group called the Federation of Associations for the Defense of Public Health, mostly nerdy doctors like Dr. Stone and myself and some of the other activists on here who know all this minutia of policy. And they just simply consistently put in the public consciousness that privatization and profitization of care is bad. You should not privatize the care. You should not profitize the care. Public care is good. Profitized care is bad. And when that consciousness was there, and the mayor of Madrid, the Partido Popular mayor, moved to profitize the system, there was a major rebellion, and the system did not get profitized. And the mayor herself signed a petition against the privatization, even though she launched it. And so this is the idea that these meetings are so important for the future of our patients. There is a major, major move to undermine Medicare as a public program, to profitize Medicare that is disastrous. When we can explain the details, that's important. But when we connect it to the undignified care that our patients are getting, and our patients are not just getting undignified care because of this particular scheme, but so many other schemes. And one of the schemes is Medicare itself went to the DRG system. So traditional Medicare, a hospital gets paid by the diagnosis related group system. That means you're upcoding all those diagnoses. There's incentive for the hospital to capture the DRG, the diagnosis related group payment, because they get paid one payment, whether it's 1 day or 5 days. It's deep, deep, deep in the American hospital culture, and therefore in the culture of all of the corporations. I think that we need to talk about everything that incentivizes treating the patient in the interest of money being wrong. Patients should get what they need and get the best of it when we can give it. And that's the bottom line. We should measure ourselves by our patients, not by schemes. Sorry for taking over. Thank you, Dr. Stone.
I appreciate that commentary, Andy. And I'm going to ask this question from Harriet Sealer to both of you. Is there general concern among your colleagues about the privatization of Medicare?
I would say
with the trauma team,
not
and
so
yes.
great.
So every single day, we have patients who cannot get into acute rehab, even though they're elegant in their early 80s with a hip fracture, can do the rehab, can do the 3 hours a day, have the insight, have the ability. Every day we have someone with a stroke or a brain injury who should have acute rehab. Those patients, United Health, Cigna, Humana, Aetna, we know all the names. We're like, oh, who's gonna call the United appeal? I hate calling United. We know the names of the insurers who are going to deny the care. We have these ridiculous conversations with, forgive me, completely failed doctors who tell you that the patient is at once both too sick for acute rehab and also too healthy for acute rehab. And you'll say, but doctor, you just said they needed acute needs, and I just told you the acute needs, and now you're saying that those acute needs are not impressive to you. They're not acute. Which is it? Because the patient can do the work to get home in 5 days instead of going to a nursing home for 20 days. They would rather pay for the nursing. This is every day. And so the consciousness on my service is there. What is wrong with these managed Medicare companies? And how much easier it is when they have traditional Medicare. But it really is in that specific context.
You know,
What has your experience been, Rob? Go ahead.
Yeah, so I talk about Medicare Advantage frequently, and in the hospital, the people who understand the problem of Medicare Advantage is just what Andy was saying. It's the social workers. It's because traditional Medicare has not great, but pretty good rehab coverage. And it is one of the favorite places for Humana and United in particular to have this health insurance policy fine print. That's how seniors are able to get their Medicare Advantage plan without having any monthly premium, is because if they get sick and need rehab, they're going to get very little time in a nursing home, and it's going to be a real struggle. And it's just the same thing as any insurance, pre-Medicare, any private insurance. People love their insurance until they get sick, and then they realize. And so Medicare Advantage is, of course, I'm really happy for this New York Times piece from, what is it now, 14 days ago or so, where they really laid it out, just how outrageous that the Medicare Advantage companies are, overbilling the United States taxpayers for more than the entire budget of the FBI or the Environmental Protection Agency or NASA. So we're getting a little bit of traction on the Medicare Advantage scandal that it is, but still there's so much money out there that I don't know if we're going to be able to change it or not, but that's not going to stop me from working on it.
Yeah, and in the last few days, I saw Kate Taylor sent an article about the Mayo Clinic not accepting most Medicare Advantage plans at this point. That was after the New York Times report. So very interesting in terms of what you're talking about. A question from Tom Wilson is January 1 a national date for all medical organizations? I'm assuming he means in terms of the launching of the ACO REACH. How much of a change are we likely to see on January 1st?
So other people may know more about this than I, but my understanding is, this is the beginning of the actual implementation of ACO REACH. And actually, I'm not certain if it's January 1 or January 2, but
it's a holiday on January 1, right?
Yeah, but this is the commencement of this new program. It's been talked about, but this is going to be it. Anybody that's participating, any organization that's participating it'll start first thing in January.
That's soon. Kate Taylor asked the question, is there a new electronic program that physicians are asked to use when the ACO begins?
Not that I'm aware of, and I would be surprised. We're all on these electronic charts, which are already, we know, being searched by artificial intelligence bots to find diagnoses. I don't think I would be surprised if in my environment, anyone wants to try to change my behavior in any ways they haven't already been. It's not going to change anything for me. It may well for others, but they've got it all wired into the electronic medical record now, and there are these, and like Andy said, there are these committees, these groups where they hire nurses to go around the hospital and make sure, prompt people to make sure they're to make sure that we're going to get paid for what we do. That's the euphemism. We don't want to defraud Medicare. In fact, we do not want to defraud Medicare, but we want to get paid. We want to get credit for what we do. That's the way they always put it.
Yes. Larry Woodson asked the question, if you are being told you don't have to do anything differently in treating your patients, how is this program improving care?
That's kind of one of the big questions that goes back to that long arcane argument that I alluded to about the original ACOs before they turned to ACO REACH. It's never been clear how they actually operate, and how they accomplish what they do, and much to the disappointment of Elliot Fisher at Dartmouth and some of the people who came up with these ideas about the original ACOs. But so these new ACOs, as far as I can tell, all they can really do is play the upcoding game.
Well, and also they take a profit away. They take profits out of the system. And it's not just that they make, let's say you make a small profit, 5 or 10% or 7%, 2.3%. They have an army of employees to identify that profit. And so the overhead of the employees is another 10%. So now they're taking, say, 12 or 15% out of the patient's budget, out of money that should go to the patient. Right. So it hurts the patient because resources that should go to the patient go to the profit scheme instead of to the patient. So it hurts the patient objectively by depriving the patient of available resources that are already in the game.
Yeah. April Chow asked the question, how does a patient find out if their doctor's ACO is ACO REACH?
Yeah, so so I mentioned that patients are getting these emails in our system. And actually Karen, my wife, got some kind of a notification about an ACO last year, and she tried to find out and called in various different phone numbers, and nobody could really answer her questions. So this whole thing, it's so complicated, and I think intentionally complicated and intentionally opaque. But patients, as far as I can tell, may get some kind of notification. It's going to be probably kind of blurred in the midst of other stuff, and also if a patient's doctor is in the ACO and the patient doesn't want to participate in the ACO, I think they have to find a new doctor. And in my town of Bloomington, I think there may be 2 primary care doctors who are not part of the IU health system, and I don't think either of them are taking new patients.
Very difficult. I apologize in advance for some people that I'm not going to be able to ask all the questions due to time, but a question from Harriet Sealer is, do you know who the private investors are who are running the ACO REACH program where you are?
So as far as I can tell, there are no private investors in ours.
Okay. I want to mention go ahead. I'm sorry.
Well, the way these things go is because we are a single integrated health system, and because we already have our Medicare Advantage program, I don't think that it costs us very much to do this ACO REACH, and so therefore we don't need private equity, and we don't need to, and our health system is very wealthy, so I don't think we need private equity. But I think that people who see all this money on the table and who therefore want to make a big splash and get into this on the ground floor, they're creating it from nothing, so they need lots of money. So that's where the private equity comes in. If you're coming in and trying to do this as a moving into a money where moving into a space where you're chasing a lot of money, it's going to cost you a lot of money.
Mhm, mhm. There's a lot of comments, and I apologize. About 3 minutes late. I was 3 minutes left, but I want to mention Robbie Stern and Puget Sound ARA because they've done some tremendous work. And he made a comment, the battle to stop ACO REACH is an existential fight for public, not-for-profit Medicare for all. I appreciated that. And I want to go back to a comment you made, Rob, earlier. How does one doctor take a stand without organizing a union? And ask Kate Tillow and Ed Gristar if they want to make any comments before we end this portion, since they both have a history of working in a labor movement and organizing healthcare workers. Any comments from Kay or Ed?
Yeah, I can say thing. Kay, are you there? But I wanted to just say that I heard Andy is in the PEF. I have to say that showing our age, or my age anyway, I actually organized the PEF in 1977. So when I was a union representative, but I've also heard all of these comments, and I have to say that the essence of what we're fighting here is the doctors and the employees, I would say, have to find out, number one, their legal status. Are you an employee, or are you some person that is not technically eligible to join a union under the National Labor Relations Act? And why is that? Because if you are union eligible, you have definite protections. Like, for instance, this idea that you can't talk to people about your contract. That is really an unfair labor practice already. But you can't do an unfair labor practice unless you are actively, collectively organizing with another employee. Technically, an individual can't do it. So as you can see, the union would give you a sense of protection and give you a way to negotiate all of the nefarious things that are in these ACOs. For instance, who sets up the ACO? What are the conditions? How is it going to benefit? Those are all issues that the union could raise in negotiations simply as a matter of information. In other words, like, once you have a union, you can request information. And many of the things, the questions that you're talking about, you could actually bargain and ask for information, which not only would help you, but it would help the whole movement that we're all trying to build, which is anti-privatization, Medicare for all. And your role in that, not you personally, but the role of the physicians and staff would be strengthened. Because without that, you're kind of like a freelancer. You're just negotiating, and anytime you ask the question, they'll say, well, just like in most cases, they'll say, well, this is a confidential issue, Rob or Andy. We can't get in touch. We can't talk to you about that. But if you had a legal union, you could overcome that hurdle. These are just general things that I think that for the people on the call, they really, if they're serious about this, they really should, because every employer perhaps would have a different legal status and a different way the system works. Because if you read some of the comments in here, some of the other people were saying they've already been told to do different things in their ACO. So not all of them run by the same principle. And it's important that we do this around the country, and we need to get some more doctors and other people and try to start mobilizing and educating physicians that this is an important part of their job. It's their working conditions, because if the ACO is so great why can't the ACO people, for instance, if I was negotiating the union contract, if the ACO is so great and you should do it, you should say, well, why don't you tell me what it is? Explain to me how it's going to help the patient. So, and then you could use that information to the general public if you had an organizing, a collective bargaining power. So
And I wonder if you could put your email in the chat for people who might want
Right.
to continue that conversation with you after this event at some point about organizing.
Yeah,
where they are.
I'm going to put my email in there, and we have also contacted an attorney she's willing. She's just finishing up a case with Google, but she's willing to discuss these legal issues with physicians and perhaps go over it step by step, so you could all be kind of singing from the same book, not doing things you shouldn't do, but also recognizing what your rights are. So I'm going to type my name in there, and I'm going to then turn it over to Kay. And if you're interested, please get a hold of me. We can have further conversations.
Great.
Thanks, Ed.
All right.
I have been, like Ed, involved all of my life in organizing, mostly within healthcare, and during the period of the 90s and beyond, tackling Humana and all sorts of corporate entities here in Louisville, Kentucky. I think that it's important to put together the fact that the working conditions and the professional freedom of opinion of those who work in healthcare are indeed the conditions for the patient's care. In other words, there's an intimate interrelationship between those who work in healthcare having rights and freedom and independence from corporate power and the need for the patient. So that's where we got to learn how to take it on. I mean, here in Kentucky, you know, we first nurses rose up and took on Humana, because at the time Humana owned the hospitals here. And that was a big rebellion, and there was a massive fight to try to block them and stop them. And, you know, as the fight went on, the corporate entity kept changing. So it got sold to Hospital Corporation of America. So now we didn't have Humana, but we had Frist, who the Frist family and, you know, those privatized corporations, then they merged with Columbia. It became Columbia HCA. That brought Rick Scott to town. So the whole city had billboards up saying, welcome Columbia HCA, because Rick Scott promised to build a new headquarters and bring us prosperity forever here in Louisville. So it's a battle to take on these giants, and they really are the corporate giants, and an alliance between organizing doctors and other healthcare workers and the community, all of us fighting for a healthcare system that is free of the profit makers, is what is hopeful. So I encourage people to keep looking at ways we can do it. And I've heard recently that doctors, nurses, and other workers in North Carolina have successfully achieved a union in a part of that state. So it is possible to get unity between different kinds of workers.
Well, I know that Judy Albert is going to wrap this up in terms of recommendations for what people can do in addition to what's already been discussed.
So I think everybody on the call has had their eyes opened, and just a really excellent discussion. I particularly like Dr. Coates talking about how we deal with the new generation of physicians and what they're facing. It's just an unbelievable job to try to explain this and to try and get ourselves into a different place. So we really need to work on this ending ACO REACH, because it should be totally apparent to everybody here that private equity is never going to achieve true equity. We need to stop the profiteering in Medicare. I think the idea of exposing patients' losses that have occurred as a result of the nickel and diming that goes on is a great idea. But we also have a petition that we're sending to President Biden, and signing that petition is something that you can do as a concrete action, and that will be posted in the chat, the link to that petition. Another action item is to look into what PSARA, the Puget Sound Advocates for Retirement Action, that have been mentioned here. They've done some full page ads in the state of Washington against ACO REACH, and they are encouraging us to call all of our senators and representatives with the message to end ACO REACH. And you can reach any of your representatives and senators in the usual way, and those links should also be posted in the chat. The number to reach them is 202-224-3121. You can also call the president at 202-456-1111, giving him the same message. And then finally, we would like to encourage people to join National Single Payer, which is the sponsoring organization of this meeting. We are interested in ending the privatization of Medicare and also fighting for single payer. And so the links to our Twitter, Instagram, YouTube through Linktree are also going to be in the chat. And we'd love to see all of your faces coming to our meetings going forward. So thank you everybody for attending. We had a total of 95 people as the total number of participants I think I saw, which is a great number. And thanks everybody for their questions and contributions. Thank you, Dr. Stone and Dr. Coates. Excellent information that we got.
Thank you. My pleasure.